I'm just going to start off by giving a short background on our OHT, as context is so important in OHT work. And then Edward will go over our earlier co-design work. And after that, I'll talk about the evolution of our governance model and how it exemplifies our commitment to patient and caregiver engagement. So in this slide, it's just our context slide. So for context, our OHT is located in downtown West Toronto and consists of more than 50 partner organizations across social and health sectors. So this includes 5 major tertiary hospitals. So we have CAMH, UHN, Women's College. We also have 5 community health centers, such as Access Alliance and Parkdale Queen West. We have 5 family health teams, several community service organizations, and around 400 primary care community providers. So we are a large, diverse OHT and have an attributed population of over 550,000. But most importantly, patients and caregivers are at the heart of our OHT's growth and evolution. And we say that patients and caregivers are at the heart of our OHT because of the early commitment to co-designing healthcare when our OHT was formed. And I feel like this ties well into the capacity piece too, because since inception, there was a shared vision that our OHT will be stronger when we bring people with diverse lived experiences to our planning tables and also to our highest decision-making table too. So this is our executive committee. And this was because it sets the stage for meaningful engagement and shared power. It actualizes theory into practice. And to give an example of our early commitment to co-design, Edward will go over the co-design work that our OHT undertook early on with the In Your Corner program and how it shapes our priorities. So Edward, over to you.
Thank you, Yasmin. I want to start with an acknowledgement and a regret. My acknowledgement is that the work that I'm presenting is very much on behalf of the Mid-West Toronto Ontario Health Team and Open Lab. Open Lab is a strong partner of ours and was also engaged to support our co-design work. So I'm very much reflecting the amazing work that they have done. You might also recognize them from the publication, The Local. They are a great partner in Toronto healthcare. The regret I have, and Francis, you reminded me of this, we usually like to give this presentation with one of our patient advisors, and unfortunately we're not able to have one join us today, but they are the true voice to this work. So my regrets there. A quick rundown of the mental health and substance use work to date, how this work evolved. I think right at the top, we need to share that the Mid-West Toronto OHT, the first 2 things we tried to figure out as a group was our governance structure and how we do co-design and how we bring in the patient and caregiver voice. So there is a high degree of intentionality with that and making sure we had a system for engagement and also making sure that all work that people with lived experience participate in is compensated at a level and fair amount. So having that in place, we were able to have the patient voice embedded throughout each of these steps here. The first one being that we selected mental health and substance use as one of our 3 priority populations, which is a task that OHTs were to take on when we first applied to become Ontario Health Teams. Then we worked with Open Lab and engaged them and sort of narrowed in on an exact population of focus and an exact area within the system that we felt we could deliver significant impact to. And that group is people who experience structural, functional, and health impacts to varying degrees as a result of their substance use and have a willingness to change. And we are looking at closing transition gaps for those individuals, so supporting them with their navigation to their desired service. From that, the work continued with Open Lab and our advisors, and we created the multi-partner navigation program, which is now affectionately termed the In Your Corner program. If anyone would like to learn more about this program, please reach out to me separately. I won't go into as much detail on the specifics of the program, except to say that it is a 24/7 navigation service where we have navigation supports across 4 organizations, and we are able to support people from their early desire need, or whether they call from a point of crisis, to a 12-week engagement to ensure that there's a warm handoff to a service that can help support challenges as a result of their substance use. This is a quick visual on how the program works, but I think just summarized it to the degree I'm hoping to in this call. This is the process that we undertook with Open Lab. So this is called the Double Diamond Framework. And the reason I wanted to share this is just to hit on two major themes that I think emerged and that we learned about as an OHT when it comes to co-design. And the first one is that the importance of embedding the patient and caregiver voice throughout the process, both from the sense of time, but also from the level of decision making. So decisions around what our population of focus, what our interventions are, made more at like an executive and all partner level. And then there's work being done, on the ground of actually engaging with users of the service or prospective users of the service, making sure that there's an opportunity for the patient voice to be heard and participate at all levels. It's something we were able to do. So across the four phases of this Double Diamond Framework, we did have the patient voice really guiding us, telling us when we were right and telling us when we were wrong, and decision making and also doing the work. The other, this is just some samples of the type of work that we did as part of our co-design and designing this net new service. The other theme that I wanted to address was the importance of having many different modes of participation. And Carrie spoke about this earlier on in the call, is trying to get that representational voice, that collective. We were able to engage over 50 voices of people with lived experiences of substance use because we designed different settings that people could participate in, from our executive table to our service design working group, to our exploration team, then to going into the actual places where people interact and hosting focus groups and one-on-one interviews. And what was really important about the work we did is that we had the peers and the actual peer advisors leading those sessions to increase the accessibility of them. It's my final slide, and I'll go quickly because I'm sure we're tight on time. But just a reminder that having the opportunity for participation from leadership down to doing the work was essential, and something that we took as a key learning that we will, is being brought from our mental health and substance use working group throughout all of the working groups of our OHT. And with that, we'll pass it back to Yasmin. Thank you.
Thanks, Edward. So now I'm going to go over the evolution of our engagement model and the rationale behind our decision making. And early on, as an OHT, a decision was made to embed patients and caregivers into several OHT tables instead of having a PFAC, so a Patient and Family Advisory Council. And this decision was made with patients and caregivers on the executive committee. And although there are benefits to having a PFAC, which I have a few listed on the screen, it wasn't the best fit for our OHT. And this is because we felt that input is often made on projects that are near final, so there's limited chance for fundamental changes, and it really requires a deep understanding of all OHT work. And it wouldn't necessarily guide our work at all stages, since input would be limited to predetermined intervals. So members of the OHT collectively felt it would be more beneficial to embed patients and caregivers as partners in conceptualizing, planning, and implementation. And this was so patients and caregivers could gain a deeper understanding of OHT work, and ultimately that would lead to richer input. So what did the first engagement model, which we called the embedded model, look like in practice? So we had patients and caregivers sitting at most working groups and planning tables to advise on and advance the work of our OHT. Here, patients and caregivers are equal partners in planning and implementation. And when I say we, I mean myself and other patient and caregiver partners would sometimes meet as a group to share experiences and lessons learned, but we didn't have collective decision-making power. And then because some of the working groups and planning tables have been on hold, the patient and caregiver partners on those tables ended up stepping off, which is where a PFAC might have been beneficial. And just to give a sense of what the embedded model looked like in practice, we can see here where the patients and caregiver partners sat at the governance and operations level. So as an example, I sat on the executive advisory committee as a patient partner, the all partners table, and the population health task force, which gave me a really rich understanding of our OHT and the work that we did, as opposed to if I was only on a PFAC. So that was our old model. And even though it served our OHT well, we felt that we could further amplify the patient and caregiver voice. And although patients and caregivers like myself were on the leadership table, we were not at the highest level of leadership, which led to ongoing conversations around governance changes to create the best environment for co-design. And most importantly, patients and caregivers were a part of this conversation. So there were three of us, Mike Creek, Don Cooper, and I, that were a part of the discussion at the exec meetings around evolving our governance. And Mike and I were members of the smaller governance working group that was implemented by the exec, which we called a huddle. After that, I chaired the selection committee where we decided to have a patient vice chair for OHT. And I'm giving a background on this process to show how creating the best environment for co-design requires flexibility and continuous adaptation. And it was also only made possible with advocacy from patient and family partners and also support from other exec members and the secretariat like Edward, because people need to be committed to co-design for it to flourish. And in these conversations, we also decided to implement a PFAC that the patient vice chair, so myself, will chair. And we saw this as an enhancement to the embedded model. And it's what we now call our hybrid model. So this leads to our current state, which is what we call a hybrid model that combines the benefits of the embedded model with the benefits of a PFAC. And in practice, we have embedded patients and caregivers that were previously involved stay on their working groups and planning tables, but are now also members of the PFAC. And new patients and caregivers can choose from one of two levels of engagement. So they can either join as a member of the PFAC, or they can be embedded in a working group and planning table and also be on the PFAC. So all patients and caregivers on working groups and planning tables will automatically be a part of the PFAC. And this is so they can bring feedback to the PFAC and also have a space to share and talk about their learning. And this model is really tailored to patient and caregiver skills and needs so that they have a choice based on their availability and time commitment. And this was based off of the conversations I had with other patients and caregivers in our OHT, because some of them wanted to be more involved and had more time versus others didn't. So it's really going to be up to them. And here is our updated model. So you can see the difference. We're going to have patients and caregivers embedded at all tables, in addition to a PFAC and a patient vice chair. And this really demonstrates our OHT's commitment to amplifying the patient and caregiver voice and creating the best environment for co-design work. And at the core of our OHT partnership is a shared value. So we believe that designing a system that works for the most vulnerable in our communities ensures that a system will benefit everyone. And our journey through early co-design efforts, as Edward outlined, and also our recent governance changes highlight our commitment to legitimizing and amplifying the roles of patients and caregivers. And the result is a democratized leadership space with shared power and decision-making. So we encourage other OHTs to really challenge the status quo and embed patients and caregivers into the highest levels of leadership. And this approach was successful in a highly complex OHT, which, like I said before, we have 50 partners, we have a very large population, so it demonstrates its feasibility. And by doing so, we really are creating an inclusive health system that truly reflects the needs of those it serves. Thank you.